Hello guys, hope you're all okay. You're all enjoying your life and you're also enjoying watching my videos, also practicing radiology and ultrasonography. Today my topic of discussion is breast related. As you know that I'm discussing breast imaging, breast imaging techniques and breast pathologies. So related to that, the first and important thing was that I should discuss how many types of imaging technique do we have for the imaging and diagnosis of the breast lesions. So this video would be related to breast imaging techniques. So in this video what I'm going to do is then I will explain about the anatomy of the breast, that different components of the breast, and the second then I will discuss about that how many diagnostic tools are available for the diagnosis of the breast lesions. Like the topmost is mammography. I will discuss about the mammography, if its different views and if its different positions. So we'll discuss about the mammography. After that I will discuss about the ultrasonography, how it will appear on the ultrasound imaging. Then we will discuss about the biopsy, radionuclide imaging, so an MR as well. So some of the features of the MR will also be included in this video. So hopefully if you once go through this video, you will be able to grab all the idea that how many type of diagnostic tools are available to diagnose the breast lesions, and hope that you will enjoy this video. So let's start watching these images. For the understanding of the breast and breast abnormalities, including simple inflammation and carcinomatous changes, it is important and vital that you should know the anatomy of the breast clearly. Here on this diagram, anatomy of the breast has been shown. So you can see on the top there is a chest wall. On the chest wall, one large muscle group sitting, which is called as pectoralis muscle. Pectoralis muscle has two components, pectoralis major and pectoralis minor. And the top of these muscle group, breast is sitting. So you can appreciate a clear outline of the breast. Let's start from the nipple area, a projection on the top and middle of the breast, which is called as nipple. This nipple receiving multiple duct and ductules from the breast lobules towards the opening on the breast surface. So that is the nipple area. Nipple area, just beneath the nipple area, that brownish skin discoloration is called as areola. So if you concentrate on the duct and ductules, these are arising from the lobules of the breast. So there are multiple lobules within the breast. These lobules are communicating with the ductules to the surface of the breast by the nipple. Beside this, if you look for the components of the breast, so there are mainly fatty tissues, but the component of the breast comprises of fatty tissue, fibrous tissues. Fibrous are usually seen in the young patients, while young women's, while fatty replacement can be seen in the older women's. On the previous image, I have shown you multiple anatomical structure, but that is the revision. Here pectoralis minor and pectoralis major are in view, so you can appreciate these two muscles. Pectoralis minor is the posterior part and major is on the front area, and behind that minor and major muscle you can appreciate the ribs. Now come to the breast area. You can appreciate that there are fatty tissues, and on the top of fatty tissues you can appreciate there are multiple lobules which are connected with the lactiferous ducts. In the previous image we have seen the ducts. These ducts are termed as lactiferous duct, and these all ducts communicating to the surface by the areola and by the nipple of the breast. A more detailed image for the breast anatomy, look for the anterior chest wall, and it shows second rib and sixth rib. So the breast ranging from second ribs until sixth rib, and here you can see their space. This second space is called as retro memory space. So there will be a memory space and there will be a retro memory space. Behind the retro memory space there will be a subcutaneous tissues, then pectoralis minor, pectoralis major, and all these are the posterior anterior abdominal wall, posterior to the mammary gland, and anterior of the chest wall has been shown, including that the breast starts from the second rib until the sixth rib, with having a particular space that is a retro memory space, which is very important in terms of looking for the inflammatory changes and extensions of the carcinomatous abnormality. Now look for the anterior compartment of the breast. So breast is divided into multiple compartments by a suspensory ligament. Suspensory ligament divides these breast compartments, and there will be multiple compartments in the breast, and each compartment consists of multiple lobules. So here on this image you can appreciate these ligament, which is called as suspensory ligament. It is again very important structure of the breast, where in terms of carcinomatous changes and their extension and their involvement, and further their treatment path, this suspensory ligament play a very vital role. So this is what the suspensory ligament divides the breast into different compartments. So other anatomical structure has already been shown in the previous images, but again it's a revision. Here you can appreciate there are multiple lobules of the mammary glands, which is actually lactating glands, and these lobules are connected with the lactiferous ducts or small ducts, which is called as lactiferous duct, and then these all lactiferous ducts come to unite just underneath the nipple and underneath the areolar area, which is called as lactiferous sinus, and furthermore this lactiferous sinus open into the nipple area, which is present at the areola. So these all anatomical pathway is very important to understand the inflammatory process and the carcinoma of the breast at length. Multiple methods has been used for the detection of the breast abnormalities. So these are called as imaging techniques. So the topmost technique and valid and reliable technique for the breast abnormality is the mammography. So mammography digital or mammography can also be used with the help of MR and even sometimes CT, but digital mammography is one of the basic and primary tool to detect the abnormality of the breast. The second baseline investigation and also investigation of the choice for looking the initial abnormalities and path of the abnormalities of the breast is the ultrasound. Ultrasound gives you a detail about the structure abnormality, the presence or absence of any pathology, and also localization of the lesion. So this you can confirm on the ultrasound quite clearly, and it's easily available, it's non-invasive, and it's a first line modality. So immediately it will help you out whether there is something suspicious or there is some pathology within the breast or not. Next comes the MRI or magnetic resonance imaging. The role of MRI with respect to breast abnormalities cannot be denied, because after mammography the important role of the MRI cannot be ignored. So certain abnormalities including like cystic lesions or some solid lesion, and on the top of it so far the metastatic status of the carcinoma is concerned, MRI is the best method to see and to localize the lesion and its extension and involvement of the retro memory space or anterior chest wall or surrounding lymph nodes or the distortions of the soft tissue component. So third in the line of methods of imaging is the MRI. Radionuclide imaging is another method of choice, I would say, in case when there is some confusion left with MRI or a mammography and still suspicions persist. So radionuclide imaging will help to organize and to identify whether the lesion is hot or any malignant potential or any other abnormalities. An imaging guided biopsy preoperative localization, and also for the confirmation of the malignant potential and the extension of malignant potential, not extension of the malignant potential, but to diagnose histologically whether there is a malignant cell, which type of a cell these are, whether these are medullary carcinoma or is a ductal carcinoma or is a papillary carcinoma. These all depend upon the imaging guided biopsy. So biopsy or FNAC, fine needle aspiration, sometime it helps to identify the malignant cells and malignant tissues. With respect to mammography, high spatial resolution is required to detect the microcalcification, because microcalcification is one of the very important sign to differentiate between the benign and malignant lesions. And the second thing is you need to have a very short exposure time limit, because increase time limit will increase the artifacts movements, while a short exposure time limits any movements artifacts. And in digital mammography, it requires a very small focal spot that should be from 0.1 to 0.3 mm to detect the microcalcifications. Grid is only the way to be used for the scattered radiation reduction. There would be scattered radiation which affect the quality of the image, and beside this, if you use the grid, it will also increase the contrast. There is always a narrow range of inherent breast densities, such as it is predominantly fatty tissues. Because of the fatty tissues, it has a narrow range of inherent breast density. So for the low molybdenum energy peaks, 17.5 to 19.6 keV provides high contrast. Low molybdenum energy, it provides high contrast, filtering reduce extraneous radiation. So the extra radiation would be filtered. During the mammography, breast compression is used. This is used because to reduce geometric and movement unsharpness. This is the one reasons for the breast compression. The second reason of the breast compression is it improves contrast, and it also reduces scattered. So contrast would be improved by reducing the scattered radiation, and it also reduces radiation dose. So the less tissue needs to be penetrated. So because of the compression, the less tissues will be exposed to the radiation. So as a result, the radiation dose will be reduced. It achieves uniform image density. By compression, you can appreciate a uniform density of the image, and it also separates superimposed breast tissues. If there is superimposed breast tissues, due to the compression, it will just slip to the sides, and the exact and the targeted lesion would be in a proper appearance, and it will achieve a uniform image density. It also highlights rigid tumors. When you compress the breast, as I mentioned earlier, that the soft tissue, fatty tissue would be split aside, and it will help the rigid tumor to be appears clearly. So glandular tissue is compressible. So when there is glandular tissue, these are compressible, and you can easily look for the rigid tumors on the mammographic images. Mammography is indicated for the evaluation of breast symptoms and breast signs, and especially focal signs in women aged more than 35 years of age. And these signs and symptoms include appearances of the masses, or if patient complains of skin thickening, or if there is any skin deformity, or if the patient complains of any nipple retraction, or if there is any nipple discharge observed by the patient, or if the patient complain of nipple eczema. So all these investigation or all these for all these signs and symptoms, the mammography would be recommended. Mammography is also indicated for the breast cancer screening following diagnosis of breast cancer to exclude multifocal or multicentric or bilateral disease. So that's why mammography is the first option to look for the breast cancer and its screening. Mammography can also be used for the follow-up of breast cancer. Not can be used, but should be used for the follow-up of the breast cancer. But one should keep in mind that it should not be frequently, more than annually. It should be annually. And the second thing is it's less frequently biannually. You can do it twice in a year, but it depends upon case to case. Normally the recommendation is that the mammography should be used for the follow-up of the breast cancer annually. Mammography is also recommended for the population screening of asymptomatic women with screening interval of 3 years in accordance with the NHS breast screening program policy. So the first is by inviting women with the age of 47 or 73 years, ranging from 47 to 73 years in England, Northern Ireland and Wales, and 50 years to 70 years elsewhere in the UK. Those women who are asymptomatic, it should be recommended. And women over 73 years, they need to self-referral. There is no need for the referral. They can directly go to the hospital and they can ask for the screening by the mammography for the breast cancer. Mammography is also recommended for the screening of women with a moderate or high risk of familial breast cancer who have undergone genetic risk assessment in association with National Institute of Clinical Excellence guideline, or in short NICE guideline. Those patients who have been treated for the Hodgkin lymphoma and they are under the age of 30 years, these women have a breast cancer risk status comparable to the high risk familial history group. So that's why this mammography would also be recommended in those who have those ladies who are under 30 years of age and those who have been treated for the Hodgkin lymphoma. Mammography is one of the important tools to investigate the metastatic deposits. If there is a metastatic malignancy of unknown origin, so the mammography would be the method of choice. If primary is somewhere else and its malignant deposits are within the breast, so the only method to investigate is the mammography. As we have already discussed about the indication for the mammography, the recommendation for the mammography, there are certain points where the mammography would not be indicated, and the topmost one is asymptomatic patients less than 35 years of age. When there is asymptomatic woman without family history of breast cancer aging less than 35 years of age, you should not opt for the mammography. This is one of the area where the mammography would not be indicated. So asymptomatic patient without family history of breast cancer less than age of 35 years. Mammography is not recommended for the investigation of generalized signs and symptoms. For example, if a woman has cyclical mastalgia, for example during the menses, if she feel pains or heaviness in the breast, so for that condition mammography is not recommended. Or if the patient feel non-focal pain, if there is generalized pain around the breast and there is no specific area identified or pinpoint pain area, so then the mammography would not be recommended. And if the patients feel lumpiness, for example, many a time during the menstrual period, female feel heaviness in the breast or lumpiness in the breast, for that condition mammography would not be recommended. If the patient is trying to put herself on to hormonal replacement therapy because of any menstrual abnormality, or in other condition where the HRT would be recommended, so prior to the commencement of HRT, if someone think that the mammography would be recommended, so it is not the case. So prior to HRT or hormonal replacement therapy, there is no need for the mammography. The next important point is to assess the integrity of silicone implants. If silicone implants are in situ, so the best technique to consider it the MR or the ultrasonography, but the MR is the top gold standard modality for the assessment of the silicone implants, so therefore mammography would not be recommended in that case. So if there is some related issues with respect to silicone implants, so MR, CT scan and ultrasound imaging would be considered rather than mammography. Mammography is not recommended for the individuals affected by ataxia telangiectasia mutated gene mutation. It's also called as ATM, ataxia telangiectasia mutated gene mutation, with a resultant high sensitivity to radiation exposure. So these patients who having ATM gene mutation, they are very sensitive to high radiation exposure, even included medical x-rays. So you cannot recommend the x-rays even for those, what to talk of mammography. So mammography would not be recommended for those who have already having ATM gene mutation. Gynecomastia is a condition where the men's develop breast because of pituitary gland abnormalities, so and hormonal abnormalities as well. So for the routine examination of the gynecomastia, the mammography would not be the recommended investigation modality. So the best investigation modality for the assessment of the gynecomastia would be at primary level there would be ultrasonography, and later the MR should be considered. A standard mammographic examinations comprises imaging of both breasts in two views, namely the mediolateral oblique, or in short MOL, and craniocaudal, in short CC positions. Mediolateral oblique view or MLO view is a standard view. It's the only view demonstrating entire breast tissues on a single imaging. What happens with the MLO is the X-ray beam is directed from superior medial to inferior lateral, usually at 30 to 60 degree angle, and compression is applied obliquely across the chest wall, and it should be perpendicular to the long axis of pectoralis major muscle. The integrity of mediolateral oblique view can be confirmed whether if it is well positioned or not. It would be well positioned if the inframammary angle is demonstrated. So you could be able to see inframammary angle, the first point. The second point would be the nipple would be in the profile. So if the nipple is in profile, it's mean the MLO view is correct, and the nipple is positioned at the level of the lower border of the pectoralis major muscle. On this mammographic image, you can appreciate that this is MLO view or mediolateral oblique view. As I mentioned, it is the standard view, and it is the only view where you can appreciate the entire breast in single image. Here you can appreciate that the entire breast is visible. The second thing is, as I mentioned earlier, that integrity should be confirmed if the inframammary angle is demonstrated. Here on this image, you can appreciate that the inframammary angle can also be seen. The second thing is, in profile, nipple is also visible, and the nipple is also positioned with the lower border of the pectoralis major muscle. Here on this image you can appreciate a right MLO and left MLO. So here just concentrate on that. First of all, you can appreciate all the tissue within a one view. The second thing is, look for the integrity. Here the inframammary angle is clearly visible, so it's mean this integrity of MLO is quite satisfactory. The third thing is, look for the nipple. Both nipple right and left are in profile, and the second thing is, both nipples are positioned at the level of the lower border of the pectoralis major. So it's mean this MLO positions, these MLO views are well positioned, and you can confidently report on this MLO view, and MLO view is the standard view. The second important standard view is CC view or craniocaudal view. So in craniocaudal view, the X-ray beam travels from superior to inferior. Through this way you can obtain craniocaudal view. The second thing is, the breast is pulled forward and away from the chest wall with compression applied from above. So this is the standard technique for the craniocaudal view, that the breast should be pulled forward and it should be away from the chest wall, and the compression should be applied from the above. Identify whether the craniocaudal position is proper and it is well positioned. So you have to look for the nipple, that the nipple should be in profile. This is the first criteria, and it demonstrates virtually all of the medial tissues and the majority of the lateral tissue. However, you cannot appreciate the axillary tail of the breast. This is the only view where you cannot see the axillary tail of the breast, but so far the medial tissues and majority of the lateral tissues are involved. You can quite confidently appreciate on the craniocaudal view. So the two views are the standard one, the MLO view and the craniocaudal view. You should have to do these in all patients where the mammograph is recommended. Look for this mammographic image. This is a right craniocaudal view and the left craniocaudal view. As I mentioned that this is the important view where you can appreciate medial tissues, but majority of the lateral tissues would be involved and you would be able to see all these tissues confidently. Here appreciate that the nipple is in profile, so you can appreciate that the nipple is there and all the lateral tissues can be confidently seen on this image. So this is the standard view for the both right side and the left side, and this is the craniocaudal view. You can appreciate on the images and you can well differentiate between the MLO view and the craniocaudal view, because these both have their own specific appearances on the radiograph or on the mammography. This is another view just for the better understanding, so that you should grab the idea of how the craniocaudal view will look like. So here this is another mammographic image, and you can appreciate that the nipple is in view and majority of the lateral tissues can be seen. The only point here with this craniocaudal view is that you cannot appreciate the axillary tail of the breast. This is only the limitation on the craniocaudal view, but for that purpose you have to pull the breast forward and from the anterior chest wall, and the second thing is you have to compress the breast from the above, and the nipple should be in profile. So this would be the standard view, craniocaudal standard view. Beside the craniocaudal view and MLO view, these two are considered to be the standard view for the mammograph. There are some supplementary views where it is necessary you can use that. So the first top one is pedal view. Pedal view, actually it localizes compression. You have to compress in a localized area with a compression pedal, and it distinguishes a real lesion from superimposition of the normal tissue. It will pop out the inflammatory or solid or cystic lesion with the help of compression. It defines the margins of the mass, so that's why the pedal view is a very important view, and it's a supplementary view, and it usually used when you feel and you see that there is a palpable mass. So with the help of a pedal, you compress the area and then take the image. So that is a supplementary view, which is called as a pedal view. So on this particular mammographic image, you can appreciate pedal view, which is a supplementary view, and it will help you to identify the lesion because of the compression. So you have to compress. Localized compression should be applied with a compression pedal to pop the abnormalities out on the image. So this will helps to distinguish the real lesion from the superimposition of the normal tissue. So here on this image you can appreciate that the compression pedal is applied and then the views taken. This is what we call it a supplementary view beside the craniocaudal and the MLO. If you think that these two projection is not identifying and clarifying the lesion within the parenchyma, so then you can have to have the pedal view, which will help you to distinguish between the normal tissue and the abnormalities within the parenchyma. The another supplementary view is the true lateral view. This is also a supplementary view. Supplementary view means like you should have to have standard views first, MLO and craniocaudal, and then after that if there is needed, you should have to have the true lateral view. The mammography unit is turned through 90 degree, and a mediolateral or lateromedial X-ray beam should be used. So what's the importance of this true lateral view? It distinguishes superimposition of the normal structures from the real lesion. This is the one of the important. And the second thing is it increases the accuracy of the wire localization of non-palpable lesion. So if you suspect any non-palpable lesion over there, you should have to have the true lateral view. It will help you to distinguish the exact pathology within the breast parenchyma. On the mammographic images, on this view you can appreciate that this is what the true lateral view will look like on the mammography. As I mentioned, that this is a supplementary view, and it will help you to distinguish superimposition of the normal structures from a real lesion. If you think that something is lying in the lateral area, so it will help you to distinguish through the lateral view, through the true lateral view, and it will pop out, and the lesion would be easily recognized on this true lateral supplementary view. Sometimes you need to have these supplementary views because some of the lesion would be dodgy and you won't be able to see clearly on the craniocaudal view and on the MLO view. So for that purpose you need to have the certain supplementary view, whether this is pedal view or true lateral view. So here again you can appreciate this is the another true lateral view, and a wire has been placed there to identify the exact location of the lesion if there is any within the breast parenchyma. So this is what the true lateral view will look like on the mammographic images. For that purpose you have to have look for the accuracy of the wire localization of non-palpable lesion. You have to put the wire and then it will help you out to localize the lesion in true lateral view, which is a supplementary view. Next comes the magnification views. Either single or multiple, wherever it is necessary. These are all the supplementary views. So it should be performed in the craniocaudal and lateral projections. It both, like in lateral view or in CC view, both projections can be used to further magnifies the area of concern or area of suspicion. These interrogate areas of microcalcification and can demonstrate teacups with benign calcifications. So this is what we use these magnification views to magnify the area where the calcifications are suspected, and we have to look for the calcification, it's a micro calcification, and we have to differentiate between the malignant calcification and the benign calcification. So the magnification use would be used for that purpose. Here on this mammographic views, you can appreciate the magnification view. This is what the magnification view look like, and here you can appreciate that the extra magnification has been given to detect the microcalcification. On the right side, you can appreciate that the red arrow is indicating the microcalcification. On the left side, you can appreciate that the blue arrow is indicating the microcalcification. This could have never been possible if you would have not utilized the magnification view. Because of the magnification view, you put all these calcification in view to identify which type of a calcifications are these, and which type of a histology characteristic of these microcalcifications are. So therefore you need to have this supplementary view, and that is called as magnification view, and this will look like as you are seeing in this imaging. So the next comes is the Ultrasound technique, and it is also a supplementary technique, and it is solely used with subpectoral breast implants. Like you have to look for the displacement of the implant posteriorly, so therefore this Ultrasound technique should be used. So how it will look on the images, let's see the next image. So Ultrasound technique has been shown on this image. Here you can see the way it should be performed, and the compression has been given from the top, and the breast has been pulled forward to put the implant in view. So through this way you would be able to appreciate the implant and its integrity of implant or its displacement of the implant. So far the leakage of implant is concerned, this is not the standard technique. You should have to have the MRI, but here still you can appreciate the integrity of the implant by using the Ultrasound technique, which is a supplementary technique. This is another image has been shown just to look for how the implant will look like. On the posteriorly you can see there is pectoralis major muscles, and here on the one image it is on the anterior aspect of the implant, while on the another image towards the right side you can see that this pectoralis major is posterior to the implant. So for that confirmation you have to have the Ultrasound technique. This is how the Ultrasound technique image will look like on the mammography. So you can appreciate that the implant is in view, and you can appreciate the integrity of the implant. So implant may be subglandular or retroglandular implants, like this would be anterior to the pectoralis major, and in some cases there may be these implants may be positioned into the pectoralis major muscle. So there is a two type of implant. So to appreciate all these integrity you have to have the Ultrasound technique, and this is what the image is showing you, that this is particularly a subglandular and or in other word you can call it a retroglandular implant, properly placed, and there is no abnormality related to the implant. So this is how this Ultrasound image will look like on the mammographic images. Ultrasound of the breast is recommended for the women with a focal signs with the age of less than 35 years, recommended by these three health professionals, by clinicians or by radiologists and by pathologists, to assess by in their clinics or being assessed by multidisciplinary diagnostic breast clinics. So in that context one should have to have the ultrasound if the clinician is recommended for the focal sign and there is some suspicions created by the radiologist within the mammogram or other radiological imaging, or maybe suspicion is created by the pathologist if the biopsy is taken and there is something fishy on the biopsy as well. So in that case, the ultrasound is very important technique, and one should have to have the ultrasound when there is some focal signs. Ultrasonography is also recommended as an adjunctive method to improve diagnostic sensitivity and specificity in women aged more than 35 years with a mammographic and or clinical abnormality. If there is abnormality on the mammogram, or if there is abnormality detected clinically, so that lady should have to have ultrasonography with a if the age is more than 35 years and the clinician is recommended, or if there is mammograph has already been taken place and the mammographic team is recommending the ultrasonography for further evaluation. Ultrasound modality should also be used following diagnosis of breast cancers to assess initial tumor size or response to new adjuvant therapy. So this can also be used for that purpose, to look for whether the size is increasing or decreasing, or there is any response to medication, if there is any shrinkage or any changes taken place after the medication or after the medicinal response, where the size is going to be shrink or increase or multiply or whatever. So that's why, and that in that condition the ultrasound is a very important and baseline modality. Ultrasound should always be used for the assessment of the implant's integrity, because the mammography is not recommended for the implant integrity and the assessment of the implants, and the MR is not indicated for the implant integrity. The important thing is just to go for the ultrasonography and to look for the implant integrity, whether these implants are subglandular or it's retroglandular or it is posterior to pectoralis major. So all these can be quite confidently assessed on the ultrasonography, and ultrasound is a very important technique for the assessment of the integrity of the implants. The another vital purpose of the ultrasound is an interventional purpose, and ultrasound can be used for the diagnostic purpose. As first point, you can confidently diagnose the lesion within the breast, whether it is solid in nature or these lesions are cystic in nature or complex in nature. The second important thing is you can also use it for the drainage purposes. For example, if there is some abscess formation or there is hematoma or there is galactocele, so the ultrasound guided drainage would be a great purpose. And follow up of breast abscess, sometime if you drain the abscess or treat the abscess and there is reoccurrence, so again you can drain that with the help of ultrasonography. So the important purpose is the interventional purpose. You can quite easily drain the abscess not only from the breast but from anywhere else within the body. The another purpose of ultrasonography is targeted or targeting diagnostic biopsy or pre-operative localization of both palpable and impalpable breast lesions. So this is the another, so you can straight away target the lesion and you can straight away use the ultrasound equipment for targeting the biopsy, for guiding the biopsy, and for taking small tissues from the breast lesion. So for that purpose ultrasound can be quite confidently used, and for the FNAC purpose you can take the targeted biopsy or from aspirate some fluid from here. So this is one of the important purpose of the and indications of the ultrasound imaging. And another important usage and indications of the ultrasound imaging is to guide axillary lymph node biopsy. This is also very important with respect to breast abnormalities, breast pathologies, breast inflammatory lesions and non-inflammatory lesions and carcinomatous lesions. So the lymph nodes always respond. To guide the axillary lymph nodes biopsy, thus informing choice of surgical management. This will help the surgical team to use the choice of the management. So that's why these were all the indications for the usage of the ultrasound equipment and ultrasound technique. Keeping in view the advantages of the ultrasound imaging, there are some limitations as well, and in certain cases it is not recommended. Like for example, if you are using it for the screening in any age group. So actually this is not the screening tool, this is actually a diagnostic tool. You can use it for the diagnostic purpose, you can use it for the interventional purpose, you can also use it even for the prognostic purpose. But so far the screening is concerned, you cannot rely on that, and you cannot conclude whether there is some lesion or not, because this is not the standard technique for the screening purpose. For the screening purpose there are other techniques, like on the top there is mammography, so one should use the mammography at all times, but for the screening purpose ultrasonography will not be the indication and it will not be recommended. Ultrasound is also not recommended in the investigation of generalized signs and symptoms. For example, if there is cyclical mastalgia, so the patient already know that during the menses her breast started feeling fullness, or her breast started feeling pain. So in that condition, while the cause is already cause is already known, so the ultrasound should not be recommended. And the second thing is non-focal pain. If there is generalized pain, and there is no point having the ultrasonography. And the third thing is if there is lumpiness. If there is lumpiness during the menstrual cycle or before the menstrual cycle, so one should not recommend the ultrasonography, because it will put some anxiety and some pressure on the patient's mind. So just to make them easy and relax, these are all cyclical changes, these are all related to the hormone, these are all related to the menstrual cycle. So in that condition the ultrasound should not be recommended. Is for the routine investigation of the gynecomastia. Gynecomastia is a disease, is a presentation when the patients complain of, male patient complain of having breasts. So ultrasound is not the first line modality for the diagnostic. There are some other criteria and tools should be used to diagnose the patients of the gynecomastia. One should not only depend upon the investigations of the ultrasound, because ultrasound is not recommended for the routine examination and routine investigation of the gynecomastia. However, if once the diagnosis is made, then you can use the ultrasonography for the further changes and for the further if there is any changes take place in the previous diagnosis, so then you can use the ultrasound imaging. But if you wanted to try the diagnosis at first point, so for that investigation the ultrasound should not be used and should not be considered. For the ultrasound imaging, you should have to have a high resolution transducer that should be from 7.5 to 15 megahertz. So it may range in between that, but it should not be less than 7.5 megahertz. Both standard views should be used. Two planes should be used, that is transverse planes and longitudinal band. The patient should be asked to place their arms behind the head, so that would be the best technique, and the patient should be scanned in the supine position, or sometime you ask the patient towards the medial aspects if you wanted to look for the medial aspect. The patient lies in the lateral oblique position for the examination of the lateral and axillary aspect of the breast and axilla. If you wanted to have the axillary tail in view, to ask the patient into the decubitus position or in the oblique position. So in that view you will be able to look for all these lateral aspects of the breasts, and also the axilla and the axillary tail of the breast. Breast tissues components varies with age, and if you are going to look under the ultrasonography, so there would be a particular characteristics of the breasts. So the first on the top image, there are three images, and you can appreciate that on the top it is written as mostly glandular tissues. So the glandular tissues usually seen in the young woman, and you will see like the component how it will appear on the ultrasound imaging. So these glandular tissue can be easily appreciated on the ultrasonographic in this way. So here this is the glandular tissue, and it's commonly seen in the young women's, and it will appear on the ultrasound images like that. The next and very common breast components are the mixed one, the mixed pattern, where you can appreciate both glandular components and the fatty components, and this is quite common. And here on this image you can appreciate that this breast shows both glandular appearance and fatty appearance. On the ultrasound imaging, if you look to the image, you can appreciate that the fatty components happens to be low echogenic as compared to the glandular components. On the glandular components, you can appreciate these are happens to be quite echogenic as compared to the fatty components. So there will be both components visible on the ultrasonography. If you do the ultrasound, and you will come across with the this type of a pattern, and this would be a mixed pattern having glandular components and having fatty component. And in the lower image you can appreciate that this breast is replaced by the fatty tissue, because it is seen in the elder patients, and in elderly patients this glandular component would be replaced by the fatty composition. So this is usually flaccid appearance would be able to see under the ultrasonography as a slightly hypoequic pattern of the breast tissues. So I would recommend here, whenever you are scanning the ultrasound of the breast, you are scanning the breast under the ultrasound imaging, always put your comment on the type of the breast, whether this breast is fatty breast, or this is a mixed type of a breast, or this is a glandular breast, because this will give the clinician an extra information. And there are certain abnormalities, certain type of lesions which are quite common in fatty composition breast, and some are quite common in glandular breast, and some are very common in mix, like carcinoma is usually seen in the glandular pattern. So there are different purposes. So therefore you are this scanning and explaining of the breast composition would help the physician and clinician and radiologist to further work on it. This is the ultrasound image in a longitudinal view to clarify the different structures of the body. So let's start from the anterior chest wall, where you can appreciate the rib, and rib is casting acoustic shadowing. So you can appreciate that this is the rib. On the top of the rib there is pectoralis muscle. So muscles has its own particular characteristics. So on this image you can appreciate muscles quite well. So you can appreciate the chest wall, and then further concentrate on the pectoralis muscles appearance, and after that look for the fatty composition and also for the glandular composition. Here on this image you can appreciate that the fats can be easily seen, and also glands can also be, glandular part can also be seen. So this gives you a pattern of breast composition, where you can appreciate any sort of a lesion, if there is any in the breast parenchyma, or if there is solid or cystic lesions lying behind. So you can confidently appreciate all these compositions and components of the breast on the ultrasonography, and always put this black and white on the report, and this would be a very conclusive report. MRI is used for the detection and exclusion of recurrent malignant disease in the conserved breast more than 6 months following surgery. Mature scar tissues which may mimic malignancy morphologically does not enhances with resultant high negative predictive value. So this is one of the very important usage of the MRI, that it should be used for the recurrence of the malignant disease within the conserved breast, and it should be after 6 months following surgery. So following surgery after 6 months, it is recommended that one should have to have the MRI scan to look for the scar tissue which sometimes mimic as malignant, and even in some cases it also causes recurrence of the malignancy in the scar tissues. The another important usage of MRI is for the assessment of the implant integrity. That is very important to look for the subglandular or retroglandular implants, or in some time if it is placed prior or in front of the pectoralis major. So this assessment and integrity can be confirmed on the MRI. If in case there is some leakage of the implant, so then you can also confirm it on the MRI images. MRI scanning is another indication is to monitor the response to new adjuvant therapy. For the new adjuvant therapy, the MRI should be used to look for their responses and how it affects the breast parenchyma and the malignant tumor. MRI technique is also combined with the mammography as a screening tool. In women deemed to be at high risk of developing breast cancer, like in mammographic section you have seen already that some of the ladies are at high risk status for the developing of the breast cancer. In those ladies, it is always combined with the mammography to look carefully and screen carefully whether there is some malignant lesion is lying within the breast parenchyma. MRI investigation is also used for the careful selected cases to clarify the equivocal or suspicious lesions being confirmed by the mammogram or being confirmed by the ultrasound findings. So in some conditions, like if you come across any abnormal lesion on the ultrasonography or on the mammographic imaging, so for that confirmation you need to have the MRI scan. MRI scan play a very vital role to clarify the suspicious lesion, whether it comes from the mammographic imaging or it comes from the ultrasound imaging. So in both conditions, the MRI scan would be the final decision making authority. MRI is also used for the investigation of occult breast cancer. 0.3% of patients present with the malignant axillary lymphadenopathy but normal breast triple assessment, like the clinically it would not be picked up, or sometime in other imaging it would not be picked up, and even in other investigation it would not be picked up. So then and in that condition the MRI would be the best technique to investigate for the occult breast cancers. For the better understanding, here in these two images, these are taken from the MR images. Here you can appreciate in both views there are normal breast tissues on the MRI imaging, and beside this there are enhancing breast tissues on the MRI images. So in these two it's quite clearly distinguishable without any doubt. So without any doubt you can confirmly say that which part is normal and which part is abnormal. So there is particular characteristics of the abnormalities on the MRI imaging. So we will discuss all these abnormal patterns in consecutive slides and in consecutive videos as well. So only the purpose of showing these images are to make you understand that for the breast imaging, the MRI scan is a very important tool which would be able to differentiate between the normal breast parenchyma and the abnormal breast parenchyma. Here another image, and this is surrounded by a round circle where you can appreciate that some sort of abnormality, very subtle abnormality, can be picked on the MRI imaging. So that's why MRI has an edge over other investigations. Whenever there is doubt on the mammogram or whenever there is doubt on the ultrasound imaging, MRI should be considered, and MRI should be able and it would be able to clarify the lesion if you seen on the mammogram and that is still confusable, or if there is any abnormalities on the ultrasound imaging and yet you are unable to make your diagnosis. So the MRI would be the only answer. Radionuclide imaging is one of the another technique for the breast imaging, particularly for the detection of the lymph node invasion by the malignant cells. So this technique is actually intraoperative sentinel node identification. So a sentinel loop or a sentinel lymph node is the first node to which malignant cells are likely to spread from the primary tumors. So the lower axillary sentinel lymph nodes can be identified at operation following injections of a combination of radioisotopes, and these are 99 technetium colloidal albumin particle, and their particle size are 3 to 80 mm, and with a blue dye. So what happens is the subareolar route allows rapid mean within a minute uptake to lymph nodes via the plexus of Seppi, and during the surgery and intraoperative procedure you can immediately figure out that this lymph node has been invaded by the malignant tissue, and during your surgery you can easily take that lymph node out. So like if it reduces the chances of leaving these malignant lymph node in the biopsy if you use this radionuclide imaging during intraoperative procedure, so you can identify the invading lymph node quite easily. So positron emission tomography is one of the radionuclide imaging in which hybrid positron emission tomography, PET CT scanning with FDG may provide additional information in carefully selected cases where restaging of the disease is required, or where monitoring response to treatment is required, or the detection of distant metastasis is required. So in that condition you need to have the positron emission tomographic scanning, or in short it is called as PET CT scan with FDG. Image guided biopsy is one of the very useful technique for the histopathology purpose. So here the best technique is used through under the ultrasound imaging. Here you can appreciate on these ultrasound imaging that first process is you have to localize the area within the breast. So at the same time when you put the probe on the lesion on the breast, so you will be able to localize the lesion within the breast parenchyma and freeze it on the screen. So on the screen at the same time you will be able to see that the lesion is under your probe. Then the next step would be that you should have to have the disinfect the area, and then after that there is a particular needle for the FNAC, or a small syringe needle can also be used to just straight away reach to the targeted lesion under the ultrasound guide. So under the ultrasound guide, at the same time you will be able to see your needle approaching the lesion, and you can easily reach to the area of the lesion or within the lesion where you need to suck either the tissue out or fluid out. So this would be quite comfortably done under the guidance of the ultrasound imaging. This image you can appreciate, this is on the first stop, there is a lesion, and under the guidance of the ultrasound imaging, needle has been placed inside and it's gradually approaching towards the targeted lesion. So on the second image you can see that the needle is halfway through the skin and in between the lesion and the skin, and in the third image you see that it's nearly going to touch the lesion, and in the fourth image you can see exactly where the needle is. Needle is exactly placed within the lesion. So you can easily take the biopsy and you can easily take the fluid for the aspiration and for the cytology purpose. So ultrasound imaging and ultrasound technique is also useful for the ultrasound guided biopsy, and this biopsy is for the purpose of the histopathology, to detect the malignant tissues and to detect the malignant cells. Yes friend, this was all about the breast imaging techniques, and I have discussed all these breast imaging techniques at length. I have included mammography, I have included ultrasonography, MRI, radionuclide imaging, and also a biopsy. Beside all these information, I have discussed about their importance, their indication, their contraindication, and in which case you will have to opt these specific modalities, and in which case these are contraindicated and you should not have to opt for that. I have also tried to provide you the sufficient images to make you understand which particular image is for the mammography and how it will look on the ultrasound imaging and how it will look on the MRI imaging. So I do hope that whenever you bump into any of the images, you would no longer struggle to recognize that which particular view of the mammography it is and which type of the breast image is this on the ultrasound imaging. And at the end, I do hope that this would be a very useful video for you to understand the different modalities of the breast imaging. So dear colleagues, keep watching videos.